Hey guys, so the following is a conversation with Najum Khan. He's the founder of iBox Healthcare Solutions. He's a data analytics and AI expert, but he's worked inside the NHS as well. So he's got real deep expertise associated with sort of NHS commissioning, performance reporting, analytics, and so on. But also, it's about filling in some of those gaps that hospital management, sort of emergency management, don't get from the standard kit. So, sort of real-time feeds. So, where it's possible to get real-time flow from EPR systems, he's able to report in real time about the current state of affairs in terms of patient delays and just the whole process within A&E and other areas as well. But he also talks about sort of integrating data from a number of different sources to get actual sort of causative explanations for things. So bottlenecks and spikes and phenomena within the process that's ordinarily isn't sort of inexplicable. He's finding associations and so on. So this is quite deep in places. We talk about the technology, so SQL and Azure and EPR systems and integration. But it's also, we touch on sort of some of the political stuff, some of the wastage in the NHS and different ways of thinking about problems and sharing solutions across sort of communities of interested parties. So my second interview as part of the healthcare series, and extremely enjoyable, and hope you enjoy it too. Cheers. Bye. It's going. Hey Najum.
Hey, Matthew, how you doing?
Pretty good, thank you. It's freezing cold here in Cheltenham. I don't know what it's like in Leeds, but so I've got extra layers on today. Thanks for being you're the second guest in this series of sort of healthcare related interviews. I think, to be honest, you were probably going to be the first. We talked about this last year, didn't we? But a few things got in the way. But could we start, Najum, by talking about sort of your origin story, how you ended up working in the NHS, what it is about the NHS that you're so obviously passionate about, and how did you end up where you are?
Yeah, so I started way back, it's 2008 now. I was working for BT in the National Programme for IT. So that's when I got the first taste of healthcare. And then from there, for a good 10 years, I've been contracting. So I moved around to Blackpool, went to Bart's Hospital, moved around a bit of London. So I stayed down London. I used to live near Bart's Hospital. So got a real taste of Bart's there. Was doing some maternity stuff in the maternity department. So got really to use to Cern Millennium. So that was one of the first early Cern Millennium sites. So really got to crux of Cern Millennium and how it was working, operating. And that's really when healthcare domain started. Obviously, I've always had a background for data and analytics and the whole SQL Server kind of area. So from there, grew in terms of analytics, in terms of scorecard, dashboard building, and as we moved around different hospitals, I was really when I got to Prince Alexander Hospital in Harlow, where I was deputy head of information. Obviously, bumped into yourself, kind of crossing each other, I think there, and Georgina King and a few of the colleagues, and that's when really realised that there was really a lack of tools in terms of pushing data out back out to the client, and that's when it really dawned on me that there's a real gap in the market there. Again, then carried contracting, was in Manchester doing transformation program, and then just through chance in terms of LinkedIn, I was posting some open data stuff about benchmarking and saying, look, why are we using proprietary software to do it? Not that it can't do it well, but here's what you can do kind of in open source. And designed a few kind of open source PHP kind of dashboards using Java charting libraries. And Hugo Matthias, a good friend now, CIO at Great Western Hospital in Swindon. So
Mm.
he's seen it online. He was like, oh, Nigel, come on, let's have a conversation. So went down to Great Western Hospital Swindon. We started a conversation. And obviously at that point, the NHS, different trusts were in different financial measures. So he couldn't procure anything major. So he hired me as a contract. He had a gap of head of information, came in there, was running head of information, but also we had a need to disseminate data back to the operational individuals and operational team. So they had a system C EPR solution was good, did what it said in terms of EPR, got
Mm.
a solid data warehouse in the HDM data warehouse, got all the data there. There was a chap, I think, who's still there, Ben Howson, who's a good data warehouse guy. Bumped into him at Barts actually, and then he's moved to Great West Hospital. And so he was running all the back end well, but it was the visualization of it was pretty basic and pretty poor. So that's
Mm.
where we started the kind of version one of iBox in terms of bringing out the data from the solution across every single ward. So we had big 65-inch touching screens across every single medical surgical ward,
Mm.
and a few in A&E. And that's when the operational folks started to understand that, we're putting all this data into this EPR system. We're getting it back now in real time. So
Mm.
when we know a patient is for referral for
Mm.
a
Sorry,
therapy,
did you say real time? Real time.
yes, so real time, so near
Right.
real time. So we were lucky in the sense that System C have got high frequency tables.
Right.
So they kind of want the early suppliers to really think differently in terms of having a standard data warehouse that's overnight feed, but then having some core set of high frequency tables, they call them. And
Mm.
then high frequency tables basically refresh every few minutes, and you can
Mm.
plug into them. And you've got not all the data, but you've got enough data to allow you to do some visuals to help operational teams
Mm.
understand the bottlenecks from A&E to inpatients to your different wards.
Mm.
Obviously, it's a lot more complex now with SDEC and SAUs and all these kind of front door type 1 to type 5 now.
Mm.
So
I read somewhere actually briefly, Najim, you did something on deteriorating patients as well. So these are patients that are approaching that level of criticality. I mean, that's an amazing piece of work. Do you want to unpack that a bit for us?
yeah, so the version one of iBox kind of was just read only from the System C EPR solution. Then we moved to Northampton where the version 2.3.4 came to life. And in Northampton they had a PAS system, not an EPR, so still running medical records on paper. And that's when the gaps kind of started to emerge in big gaps. So this was
Mm.
pre-COVID, we've been there 8 years now, so this was just pre-COVID, and that's when we started to bring data to life on the ward. So not only now was it read only from the PAS system of Najum Khan's in bed one, but it was now what pathways you're on, what tasks are
Mm.
outstanding, and that's when the data entry started to happen in iBox in real time on the ward screens,
Mm.
and that's when the clinical safety officer and the deputy medical director, Dr. Jonathan Hardwick and Charlotte Hoodless came up with the idea of treating patients. They're like, we know there's a. It's not that the doctors are not doing it, but it's about you having that prompt to do it. So we know everyone's busy. We know
Mm.
everyone's maxed out in hospitals, and systems have to be prompting people to do the right thing at the right time.
Mm.
So that's when deteriorating patient, the team knew they're the most sickest patients across the hospital. They're the ones that need the most demand. Therefore, when someone trips over 5 on an early warning score, put them into basically a virtual ward, which is basically a cohort of patients within your hospital, could be in different wards scattered around, but here's your defined list of deteriorating
Mm.
patients.
Yeah.
And therefore, then you can interact with them patients, add the commentary as you need to, remove
Mm.
them from your list. For example, Najim Khan's, his early one scored 777, but he's on an end of life pathway. So we know he's high because he's end of
Mm.
life pathway. We don't need to have him on our list, so we can suppress that alert in a
Mm.
safe, controlled manner. And because iBox is built in that way, where we're full Active Directory
Mm.
synchronization, where we're full governance, so and we're full on-prem in Northampton, we can track every user interaction, who silenced what alert, when, what, why, and if any incident happened afterwards, we can trace back the entire episode of care for that
Mm.
patient iBox. So therefore, we started to learn that when we started to have these prompts on the wards to do certain tasks, so 13 key tasks they've defined. Again, I'm not a clinician, but I just know there's 13 tasks to do, and things like TEP and sepsis and AKI, all sorts of metrics I measure. But again, the actual clinical activity, the clinicians know what they need to do. You just have to remind them you have to do this
Mm.
task.
Mm.
So the study was done over 2 years at Northampton Interior patients, and it found that if these would be prior pre-iBox, these tasks used to take about 72 hours to roughly do all the 13 tasks, or at least come back. But post iBox, we got that down to a few hours. So
Mm.
now all the doctors, consultants, CCO team knew, right, these tasks appear on iBox. We know what we have to do. Let's go on and
Mm.
do it. And it showed that in doing them tasks within the 4 hour, 4 to 6 hour, kind of 8 hour time time window, we did time series analytics. We showed that through them decisions, number one, you reduce the usage of the critical care ward. Number two, you reduce the risk of cardiac arrest to patients who are high risk.
Mm.
And number three, you create that safety net where in hours or out of hours, everyone knew what had to be done. So you
Mm.
create that entire standardization of working for the more sickest patients,
Mm.
meaning the outcome of the patients were better. The mortality rate of Northampton dropped for them 2 3 year period where we were doing deteriorating patient.
Wow,
So
that's
they
amazing.
wrote a paper on it and they published it in terms of showing all this, that it
Mm.
isn't just about an EPR recording the investigation,
Mm.
diagnosis, and everything else. It's about having them data-driven decisions
Mm.
where you've got flexibility of a system designed
Yeah.
around a working process by clinicians, and
Mm.
then the data geek myself and co-build the system to work with them, and
Mm.
therefore then you show the real value of data-driven decisions. And that was
Yeah.
kind of the crux, and the whole originality of iBox was to showcase that it's not about being against any major proprietary software, Microsoft, Oracle, everyone. They're fantastic in what they do,
Mm.
and they know what they do. It's about showcasing that these little gaps, deteriorating patient,
Mm.
discharge tracker, infection control, these little gaps, the
Yeah.
major EPRs don't cover them, not well,
Mm.
because they kind of bespoke to each hospital. Every infection control team works a
Mm.
bit differently. Every patient team works a bit differently.
Yeah.
Everyone's got different capacity in how many critical care beds they've got versus how many team members they've got at certain levels. So everyone's different, meaning you can't do a one size fits all. Hence why the flexibility of iBox is right. You've got your major EPRs, fantastic,
Mm.
but what you're doing about this core little cohort of patients that you can help, and it's always the 80-20 rule, isn't it?
Mm.
You always find 20% of patients cause you 80% of the long length of stays, and if you manage them well, you
Mm.
really reduce your length of stay, reduce your infection risk, reduce your outbreak.
Mm.
Hopefully, you're increasing your flow across your whole system.
Mm.
Hence why the pivot of iBox was is that it's pivoted now more towards a control room solution. So when you look at
Mm.
hospitals now, you've got two areas. You've got one is patient care, which is your EPR, patient centric, fantastic, knows your investigation, diagnosis, what task have to do next, what's the medical status of the patient, doctors, consultant, nurses, governance.
Mm.
Yep, fantastic, done. But the next level is now system level. So has the board round been done? Yes or
Yeah.
no?
Yeah.
Is
What's
my
happening
EPR,
now? What's happening
yeah,
right
is
now?
my
Yeah.
EPR exactly? Is my
Yeah.
EPR up to date? How
Mm.
many medically optimized patients do I have across the
Yeah.
whole hospital that I can safely discharge? How
Mm.
many patients are on pathway 2, 3 where we need an external supplier to do something, an external provider to do something? What's the state? How many infected patients do I
Mm.
have in which side rooms that I can move out safely to move another patient in? So
Mm.
all them little kind of site kind of overview kind of metrics that are
Mm.
not really EPR is designed for. It
Mm.
collects all the data fantastically well and can do patient care fantastically well, but it's that system level stuff where you see in a lot of sites now with spreadsheets in the site office, with
Mm.
spreadsheets managing things, with Word documents,
Yeah.
and they still see that even after they invested so heavily
Mm.
in major EPR providers.
Yeah.
And it's not to detriment of them, it's just to say they're not designed to do this, and that's where kind
Mm.
of iBox is, that kind of that control room, site office flow kind of solution.
That's really interesting because I think exactly as you said, discuss this with Hugh as well. So the suite of kind of statutory reports they've got, even some of the standard performance reports you find inside trust, they don't actually help with tactical interventions. They don't tell you what the current pressure is inside A&E, and this is why you end up with spreadsheets, isn't it? Because the generic systems aren't delivering those on those gaps that you're now looking to occupy. I mean, this is fantastic. So you've saved lives. You actually, just to be clear, you said the mortality rate has gone down since this intervention, and I love the sort of holistic approach as well. You've done the research, you've studied it for 2 years, you've done the anthropology. It's kind of systemic anthropology. You've come out with a logical solution and delivered it. I mean, that's why you're here, because that's really fantastic. So could I just ask, could we backtrack a little bit and just ask what your view is on the performance culture? And so, the various reports that get submitted to Unify and so on and so forth. I mean, there is a place for those, right? But it's quite a burdensome thing as well, isn't it? Any thoughts on that whole sort of domain, if you like?
Yeah, I think that entire performance culture I think is needed. So there is a need for governance. There is a
Mm.
need for having openness because obviously it's public money. So we have to understand, what our hospitals doing, where the performance is, and how they're heading. So that openness is needed. But the way we've gone about, I think, over the past decade has been so custom to every single hospital.
Mm.
If you look at mixed sex accommodation, a kind of simple basic report saying at midnight, do
Mm.
I have a patient in a bay who is one gender and someone
Mm.
else another gender?
Mm.
Such a
It should
simple
be easy, yeah,
algorithm
but it
to
isn't.
any data person. That's the most simplest thing in the
Mm.
world. Now, how is that not automated and
Mm.
standardized across every single hospital in the
Yeah.
UK is beyond me. Because we've just got so many archaic ways of
Mm.
measuring how many beds do I really have.
Mm.
Is that a boarding bed? Is that an escalation bed? Is that a one-up bed? Is that a chair? Is that kind of a temporary space, so I shouldn't
Mm.
really use it? And
Yeah.
there's too many places to, is that ward open or closed?
Mm.
When was it open and closed? And there's so many levers to that one metric. It's kind of no wonder why it's still in the spreadsheet.
Mm.
So I think that the the reason for doing it, for centralizing things, is fantastic. It makes sense. Someone can hold you to account. The
Yeah.
methods we've got for doing it are kind of still stuck in
Mm.
some dark ages where we need to really upgrade and change. If we're
Yeah.
standing, hopefully, we'll see the versions of when we're standardizing now EPRs across the whole estate. You might see that hopefully once one site's done it in Cerner, hopefully they can help other sites do it the same way and they can all standardize it. But then you've got the wonderful FTP in the middle, so you're hoping that FTP can consume all this data and standardize a lot of these things and remove them. Now, if it doesn't, then it's just an extra burden which
Mm.
you find whilst you're parallel running the old
Mm.
way of working.
Yeah.
And that's where you see the BI teams. I feel sorry for them because they
Mm.
just have to do the old way as well as do the new way. And
Mm.
there's no guaranteed timeline to when the
Yeah.
new ways take over the old way and they can stop doing that.
Yeah.
So they've
Yeah.
only got the capacity to do the old way. Now, with that same number of staff, they have to figure out the new way
Mm.
and then carry on running both of them. And
Yeah.
then at some
Yeah.
point, discontinue that. But it could be years down the line.
Just briefly on that, Najum, there's something sort of ironic about this, and I think what you've just described is one of the reasons those analyst jobs are actually some of the best jobs in the world. I mean, they're some of the hardest, but because you've got to do everything, you've got to do a bit of development, a bit of BA work with the customers, the principal analyst kind of role where you're speaking to the heads of specialties and stuff. And then you've got to do the spreadsheets, the SQL. It's one of the most multifaceted roles there is because of these, ever-changing challenges you're talking about. But it's bloody stressful, isn't it? As well, and that's where you guys are coming in. You'll say, look, well, because actually, one thing I was going to talk about is the problem of integration, right? You've got different EPR systems, different hospitals. You've got Cerner and loads of different products from different countries. You ask yourself. So there's one thing I wanted to get onto is the idea that the NHS is the fourth or fifth biggest employer in the world. So why the hell doesn't it have its own centralized IT function? I mean, I guess in a way you were involved in trying to build something like that, weren't you? At the start of your career, but in the NHS. But yeah, any thoughts on that? Why don't we have our own freaking IT department, and why do we give so much money to Cerner every year?
Yeah, it's a tough one, isn't it? Is on one hand they don't want to be seen as a technology company, they want to
Mm,
be focused on patient care, which is fine. But now in the 21st century, unfortunately, patient care and digital tech is just hand in hand now. You can't do one without the other. So
mm,
it's kind of it is a very tough position to be in, and it's very political as well in terms of if they start to turn to hand to software development, they probably could do it. But again, they'll have to hire all the expertise from all the software companies to do it. So it's kind of
mm,
a difficult one, is it? It's that privatization versus, bringing it in house. If you look at
mm,
the water, the rail, post office, unfortunately, with the Horizon scandal, it
mm,
doesn't lead well when they have privatized it. Now, whether that's just because they privatized it in a way that benefits the private company, so much so that they have all they have all the levers to do whatever they want whenever they want, and they're not
mm,
accountable to no one, as we've seen with the post office scandal. Now, if they're doing the same thing with the FDP or Palantir, with Cerner, with Oracles, and everyone else saying, right, you house the data wherever you want. You say you're looking after it for us. You say you're doing a fantastic job. But who's really holding them to
mm,
account if we don't have an internal kind of data warehouse expertise that can say, tomorrow I can walk to any hospital, lift up the lid and look at, say, exactly where the data is, exactly who has access to it, and exactly what you're using it for. So
mm,
if we don't have them internal functions that are level par with the suppliers, we're just going to
mm.
get overrun where the suppliers are going to tick box and
Yeah,
say, we are doing this. We've
yeah.
got no means of checking it.
Well, there's
And
a
then
pretty good
tomorrow,
reason for this, Najm, is that the suppliers are paying them more than the NHS can afford it. I mean, I've seen some brilliant data warehouse managers in the NHS over my years, and they're dedicated, really committed people. But yeah, they're on probably half as much as they'd earn if they were working for a private company. So it's
and that's the
another
key
problem.
thing. We've built this pay structure, we've built these frameworks into how we can operate it within the envelope of money. Whereas for the private companies, that doesn't exist.
Mm,
So it's tough, isn't it, as to why we're so far behind in
mm,
internal. And as you know, is the BI function was never seen as a critical function in the
mm,
NHS, at least for the past 20 years. It's only the past
yeah.
4 or 5 years it's really lifted its head. You've
Mm,
still got trust that don't even have a CIO on the
mm,
board, and
yeah.
that's only just come to light. So it shows how far behind we are, whereas the technology companies have always been driven by data. They've come from other
Mm,
sectors of finance, of defense, of manufacturing, where it's all been data driven and data led. So they're coming in with a lot more data kind of expertise into
yeah.
this space. Where you're right, you find only, unfortunately, the scattering of one or two guys across 5 trusts who might really
Mm,
know what they're doing. But but whenever you always know, whenever you find a good guy in the hospital, he gets hammered by everyone to do everything,
Yeah,
and he never
exactly.
has enough
It's
time to.
80/20 again, isn't it? It's 20% of the
Yeah.
staff are doing 80% of the work.
Yeah, so he never has the time to lift his head up and say, why don't we try this? And that's where the problem comes is they don't have that capacity to innovate or that
Mm,
capacity to look at these gaps in enough detail because they're not an innovation
mm,
company, they're not a technology company,
yeah,
they don't have R&D departments. We don't have any of that. Whereas Oracle private company, they're going to clearly invest heavily in that space because they
mm,
know locally won't be able to do it. So that's where they
yeah,
kind of win. It's a
yeah,
very difficult place, isn't it? Is that even if you look at any of these trusts that have tried to build their own data warehouse internally and try to do their own capacity internally, they've always unfortunately come stuck where they've had to rely on contractors. And now with
yeah,
budgets being slashed and contractors coming, scarcely available and moving technology and legacy things, it
mm,
unfortunately the trip up. So it's a
mm,
tough place to be in. It's a
mm,
tough thing to understand in terms of why we don't do it internally, but
yeah.
we are
But
where
we
we are.
don't. But yeah, that leads me back to the the question of integration. And you touched on this earlier. It's ridiculous that we can't sort of join the activity data with, say, bed management data. You know, that kind of thing. It's like, well, we should instantly be able to tie an outpatient appointment to someone who's currently in a bed, for example, right? To be able to reconstruct the whole pathway, and that's tricky in some trusts. So again, iBox steps into that space and says, okay, so have you had much success with integration across different systems within the NHS? And I was going to say, do you have any favorites, any particular EPRs that you prefer over others, or diagnostic systems and that kind of stuff? So,
Yes, integration has always been tricky in terms of how do you successfully integrate into an EPR or into a PAS system or anything. And it's kind of been lucky in the sense that even with Camis, which was owned by System One, in terms of a lot of these databases, they have when you come to technology, you have asynchronous replication in MySQL Server. In Microsoft SQL Server, you have it a lot of these systems. They have always a primary and a failback in terms of secondary database.
mm,
So you have a lot of these systems that allow you access to the real-time data as long as you do it in a controlled way.
mm,
So I understand HL7 Fire API, but they don't exist with these legacy systems. They don't exist with even some of these current systems in a very intelligent way. So
mm,
you have to unfortunately find ways of basically going back into their raw database, reverse engineering their logic to
mm,
extract the small bit of data you need to, in order to make iBox come alive and then do what it needs to do afterwards.
mm.
So I always try
So
my best to.
you're not just copying and pasting there. It's
Yeah,
actually it's quite an intelligent sort of query that conditionalized
exactly.
outputs
So
and stuff. Yeah.
yeah, we have to make sure that our ETL and pipelines extract the data we need, but don't put a burden of performance on that secondary database. So because if
Mm,
it is needed, then you don't want to be a hinder to them. So you
mm,
want to try and make sure you do it in a way that you only take, follow core rules, only take the data you need, only minimize the amount of times you need to pull it. So if it's every 5 minutes, you can get away with
mm,
net changes. If you could do it every 60 minutes or every 3 hours. So build your pipelines in such a way that you burden the live system as least amount as possible,
mm,
but also get enough rich data out so you can then build the pathways going further down. So that's the
mm,
key thing you find. If you look at Somerset, it's a Microsoft SQL Server based. If you look at System C, it's Microsoft SQL Server based. So Camis is kind of an old Infomix database, but again, the secondary database is live. Oracle runoff, obviously, they're moving over to Oracle databases, but it's housed in AWS and it's kind of an old school technology. So again, you can do an
mm,
ODBC connection into their databases. So there's all sorts of different means of doing it, and this is the
mm,
whole power of open source technology, not putting yourself in just a Microsoft house or Oracle
mm.
house, is being flexible to have
Yeah.
little tools, like Elasticsearch and Elasticsearch and a few other things that you can plug into different things, extract the
Mm,
data out you need it, and then
mm,
build your pipeline. So, you've got Apache Hop, you've got Apache Spark, you've got different things, different tools for different scenarios of real-time data versus near real-time data, and you can extract it and do as you need to do from there.
mm. Najum, could I just ask, what about sort of data governance issues and things like, person identifiable data and things like that? How do you cope with all that stuff?
So as part of a company, obviously we have to be DTAC and Cyber Essential compliant and everything else. So we always put our solution on-prem. So we always ask the customer to spin up an infrastructure server on
Mm.
their infrastructure so
So
they
they
can
own
manage
it.
it.
They own it, right?
Yes,
Yeah.
they own the infrastructure, whereas we own the software. So we say, look, the
Mm,
infrastructure is yours. You give us a server. Because we're an open source web platform, we don't need a six server farm with
mm,
multiple CPUs and 200 gig of RAM. We just need a lightweight kind of 64 gig of RAM kind of machine, which is kind of available in all virtual environments nowadays. And on-prem, they've kind of invested in data centers over the past 10 years. So we've never found an issue of hosting it on-prem. And
Mm.
then from there, we allow them to control all of our Active Directory connections to all their databases. So we say, look, this is our
Mm.
AD account we're using. If you find any issue on your network, just to shut it down. And obviously,
Mm.
we'll investigate afterwards. But we also ensure that on our server, we track all the logs. We log every ETL, if it failed, why it failed, its performance issues. So we always do health checks every day on
Mm.
our iBox to make sure that everything we're pulling from where the health check kind of confirms, yeah, it's pulled it in 4 seconds, we've done well. It's
Mm.
pulled it in 19 seconds. Hold on a minute, we need to look at that and fine tune it. So we're in a position where we fine tune everything to work under 10 seconds in terms of
Mm.
pulling data from different sources. As soon as
Mm.
it trips over that, we get an alert and then we kind of
Mm.
look into it because
I was going to say,
it's
I bet you probably find out about some of the source ETL stuff before they do, don't you? So if there's a
yeah, that's
fee, if there's something fails in EPR, like an extract's not delivered, you'll probably know before they do.
that's the key thing. Being a small supplier, obviously
Yeah.
we're kind of flexible and agile, so we
Mm.
kind of focus in on being the best we can. We know that as a small company, you have to be 100 times better than everyone else. And
Mm.
I focus less on the finances, probably hence why I'm not rich. But I focus more on the value I give to NHS. So
Yeah.
it's not about being, you know, pro open source versus priority and saying, oh,
Mm.
we're a lot better because we're flexible. But it's about
Yeah.
saying, look, it's as good as in
Yeah.
different scenarios. Yeah, fair enough. You might need an Oracle Cerner as your major EPR because that's a humongous piece of work. And
Mm.
yeah, I won't try to build that from scratch. But getting the data out and visualizing it for an infection control module, yeah, why
Mm.
do you have to do that in some big tech again? Just use something
Mm.
lightweight where you
Yeah.
can do it successfully as well.
Yeah, I mean that's reflected on your LinkedIn profile. Your introduction is beautifully written, by the way, but it talks about the fact that your main emphasis is actually trying to help the NHS save money, save patients, save effort on the part of these operational and analytical teams and so on. So we've had a chat already about some of the AI stuff going on because you've already got some AI implemented within your technology, haven't you? And some smart stuff going on in there. And I know that you have expertise in this field as well. So it'd be nice to talk about the whole scene of LLMs and maybe AGI as I did with Hugh the other day. But could we focus on what kinds of intelligent processes you've introduced already using AI?
Yeah, so we're still in the research development kind of space, but what we're looking at is as we see the BI teams are kind of overwhelmed with the amount of work
Hmm.
they have to do. So, and obviously that's kind of my kind of core space. So there's two things we're looking at is number one is matrix of metrics. So the whole purpose of matrix of metrics is to understand is that when one metric is red, why is it red? What are the underlying reasons for
Yeah.
it being red? So if you've got high number of attendances in A&E, it doesn't necessarily mean it's a bad thing because you've got high number of attendances, but
Mm.
what's the knock-on impact if them attendances, if the conversion
Convert.
rate is
Yeah.
12%, what's going to
Mm.
happen? How many beds are you going to need? When are you going to need the beds? Now, if you have
Mm.
a 200 bed hospital with 20 empty beds, you could probably cope with it. But if you've got a 700 bed hospital with 10
Mm.
empty beds, then you're not going to cope with it because your bed base, your occupancy rate is at maximum anyway. So
Mm.
therefore, it's about understanding the knock-on effect of a metric to understand if this metric is red, what are the underlying ones to look at in order to
Mm.
alleviate the pressure on that one red metric. So that's kind of the first thing. And the whole purpose of that is to be intelligent is general managers and operational managers don't have time to always pivot a spreadsheet of data every single day to figure things out. So it's about doing that in real time and direct them and saying, look, stop looking at your A&E kind of bottleneck in terms of your 4 hour breaches. Look
Mm.
over here, you've got no beds, that's why you've got 4 hour breaches. Or look over here, you've
Mm.
got patients who shouldn't be in hospital, who are medically fit and should be out the door, who are still stuck in the hospital because they can't
Mm.
get a local authority package of care. So how about you go kick over there? That'll
Mm.
release you 10 beds, which is enough to alleviate the pressure on A&E. So it's try to direct people to say, look, stop focusing on things in silo. In the
Mm.
healthcare system now, as we are, we're a system. So you can't just focus on one element. You need to focus on all the verticals that have a
Mm.
knock-on impact and effect. So that's the idea of matrix and metrics. And AI will help in that because it can hopefully start to compute all the metrics in near real time. So let's say it's doing all these metrics,
Mm.
100, 200 metrics every 5 minutes. It can then help direct you as a chief operating officer. I come into the hospital this morning. What is my major concern? And it can start to talk to you. And as it learns and grows and understands right, we're in winter now. Winter pressure means X, Y, and Z.
Mm,
Summer means we need to increase our elective capacity. So as he starts to learn from the seasons and from what
mm,
you're trying to achieve, and then as you start to put your plan in there, I need to
mm,
achieve X number of hip operations this year, then you can start to say, well, to do that, you have to
mm,
have this much bed capacity because you need pre uh, pre theatre days, post theatre days. Your theatre capacity has to be this. You have to have this number of surgeons on. You have to have this capacity of inventory on. So all the knock-on effect in terms of
mm,
inventory, medicine, cleaning, portering, and everything has to be factored into the whole planning
mm.
now, rather
Yeah.
than everything being done in silos. So a job card for a consultant might be fantastic, but if the consultant doesn't have the room and equipment to treat the patients,
Mm,
what's he going to do? If the consultant is off on annual leave, have you notified all the patients and have you stopped all the messaging going out? So it's a whole these knock-on impact and effect that through the matrix of metrics, so you can start to program into this engine that can start to learn and direct.
mm.
And then on the back of that, the
So
analytical
just
thinking.
briefly, so it's kind of basically it's observing other variables at the time that something's happened. So if there's a spike in attendances, and then you can look at, well, actually, when this last happened, there was an increase in medication over in this department, or there was some bottlenecks here, that kind of thing. That's freaking fantastic. Yeah.
Yeah, so if you look at the pharmacies, pharmacy is kind of big in every single hospital,
Mm,
and you've got a lot of inventory there. So it's about tracking the inventory.
mm,
What drugs are we using more than others? What drugs are we holding stock more than others? And if you look at your inventory of even going out to your meals and your foods, if you've got a high number of inpatients who have been in the hospital a
mm,
long time, you start to know their meals and start to know what they're eating. But yet, if
mm,
you've got high turnover, then you've got to create a new meal card every single day. So about notifying the meal team and
mm,
reducing the waste of saying, right, Najum Khan has been discharged at midday. I know you might have made his meal, but fortunately, it's going to go to waste. So it's about emphasis.
mm,
It's about predicting that, saying, look, he's most likely to be discharged at midday. Stop, don't make his meal. Ring up the
mm,
ward before you do it to get to ensure because he was down as a definite discharge today by the
mm.
nurses because he's ready to go.
Yeah.
So it's about triangulating all them little things, and it's all them little things of waste of reducing them phone calls or reducing them emails or reducing that non-clinical kind of communications and
Mm,
having that all systemized and automated that will give the real capacity back to the consultants and nurses to do the clinical things that can
mm,
help productivity gains and help get patients out the door
mm.
in terms of wellness and care and safety.
Yeah, I love that. I mean, you're talking about sort of tactical interventions based on this, but I'm thinking again, I mean, you probably already consider this, but the strategic level, is there anything, I mean, have you seen any good implementations of predictive analytics that kind of look at seasonal impacts on A&E and things like that? And I know that the NHS, haven't they released a standard A&E predictor tool as well? I don't know whether you've heard of this. I don't know whether I
Yes, and
haven't
the
seen it.
FTP is
Is it any good?
not seen in action. It's supposed to take the Met Office data together and forecast it on
Mm,
weather and forecast it on any attendances. Now, things like that are useful and good, but the problem you've always got with these sort of tools is it's kind of something that everyone knows anyway. Maybe it might be more
mm,
accurate, but the
mm,
headache you've got is people kind of, in my opinion, kind of focus on the wrong things. So your biggest expense in any hospital, as you said, is the biggest employee, fourth or fifth in the world is your consultant bed based? Is your consultant
mm.
based? Your consultant and clinical nurses? Now you have to look at your rotas and system. Now, if you can't triangulate your rota and your staff in your
That's
system with
it. Yeah,
activity, there's
yeah,
no point telling me I'm going to have a high number of
yeah,
A&E attendances.
yeah.
What's your point?
Mm,
I need to be able to adjust my clinical workforce
mm,
in a very sophisticated manner
yeah,
against my activity in real near real
yeah.
time. So whereas next week I might have four registrars on, why when your activity
Mm,
is going to be double what it is this week, you need actually eight. Oh, I didn't
mm.
think of that. So
That's
that's
absolutely
where
right. So your
useful.
staff coverage has to be perfectly aligned to that kind of, what should we call it, a pressure curve, if you like, something like that. And if you can get them in line, then you never be any wastage, and you never be overstaffed. So,
And that's
but obviously
the
it can't, you can't manage spikes, sudden, events, random events. But yeah, I mean that's the way forward, isn't it? But so many trusts don't do it.
yeah, because it's unfortunate is the workforce systems have always been a silo in one place,
Mm,
no access to it. It's very hard to get the data out. It's very difficult to people aren't doing it a lot of spreadsheets, and then they
yeah.
can't align the activity with it. Again, it's about time and capacity. Now I've got to
Mm,
go in and run some reports to get that activity out, to
yeah.
align to my workforce, and how many registrars do I need, and how many specialty consultants do I need in? What's my kind of elective recovery plan saying? How many hip operations or TNO can I do? How many
Mm,
ENT doctors do I need? So it becomes really complex in terms of your PAs that you have to manage by consultants. So
Mm.
it is a really complex thing to even start to think about.
Yeah.
But I'm pretty sure a lot of people would have done some good around it. So it's about bringing them heads together to understand, right, if we've got a certain EPR implementation and
Mm.
there's 35, 40 in the country, can't we all pull this data up from here,
Mm.
have this workforce rostering system, pull this data up from and bring it together, and then build that into the FDP, which is exactly what is needed. So in
Mm.
my mind, the kind of stuff that he's doing that's A&E forecasting tool is bread and butter. You can do it on a spreadsheet. So
Mm.
nothing can be done on a spreadsheet. Why are you wasting the FDP's effort?
Mm.
Even what you're
Yeah.
showcasing, you can take a
That's
spreadsheet.
really interesting. So you think sometimes actually local spreadsheet solutions are actually what fits the bill because it's low cost. You've got local expertise. You're not messing around with existing infrastructure or anything like that. You do a piece of analysis and right, okay, that's really interesting because I felt this sort of 15, 20 years ago when BI platforms are coming through. It's like, oh, let's automate everything. You know, we've got to have dashboards, we've got to have dials. But you're actually saying, no, 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 let's just be sensible here and spend the money where it's really needed. Yeah.
Exactly, exactly. So, and that's the key thing. If you spent £340 million on a database and all it's telling me is forecasting my A&E attendances, I'm going to be
Mm,
pretty ticked off with not value for money. So,
mm,
what I'd rather it tell me is, can it mop up all the elective activity from every single hospital in the country, bring it all together?
mm,
Then you've already got technical or every you from the GMC, you know every consultant you've got in the country, you know who they are, where they work. You
mm,
mop all that up and then say, right, what can we achieve over the next 12 months with this consultant base and
mm,
this theatre? You know every hospital, exactly what type of theatre they got. You know every single thing what's going on there. So you got your theatres, you got your consultants, you got your elective waiting list, basically PTL. Why
mm,
not? Why is someone not munging this together and saying, Najum
mm,
Khan, if you want a hip operation, get on the train. We'll pay for you to go to Royal Free
mm.
because they've got capacity to do it and get him off the waiting list.
Yeah.
No one's thinking about how we can build a dynamic kind of waiting list that
Mm,
says, gives a patient the choice. Are you willing to travel? If I
yeah.
need a hip operation, I'd be happily willing to travel
Mm,
on a train to London. And if they can do the operation for me tomorrow, I'd definitely go do it. So why
mm,
is no one not thinking about dynamic waiting list
yeah.
management within the FDP? Because if you tell all this trust to put all the information in there, it needs to
Mm,
give the really productive, really big back to say, right, that's worth my bang for my buck.
mm,
340 million, I can see where it's gone now.
yeah.
Whereas telling me an A&E forecasting tool is kind of
Mm. That's
21st century. You can do it.
that's fascinating. I mean, there was a piece I worked with a chap called Richard Cartwright. I don't know whether you've heard of him. Been was it North London CSU, was it? And basically, the NHS do things like this, but they only do it in response. It's reactive, isn't it? It's like, oh my God, we're in an absolute mess. COVID had affected things, so loads of people had fallen off waiting lists. So there were the ghost kind of patients that were slowly coming back on and things like that. And basically, they're an absolute mess. And patients were, there was loads of 2 year breaches and things like that, right? And so they did this kind of we call it demand flattening. So we're doing exactly as you've just said. So basically saying, look, there's 3 hospitals here, and this patient's been on this waiting list for, say, Royal Free for 2 years. They could have gone to one of the other hospitals whose waiting list for that particular specialty is nowhere near as bad. So basically, we just said, let's just view this one patch as one big waiting list. And yeah, I mean, they had some great success there and actually got people off. They reduced the 52-week breaches and all this kind of stuff. But yeah, there's not enough of this kind of integrated, sort of top that I don't know, sort of strategic thinking going on. Again, because of the tactical demand of people banging out the statutory reports and doing reports that don't really help anyone. So yeah, we're back onto AI. So how do you feel about language models and their place? I mean, I mean, I've seen a couple of projects where they've been used to kind of compress text messaging and things like that. So you have to pay you don't pay the mobile phone providers so much and things like that. But it's few. I haven't really seen any big major scale sort of projects that have delivered anything fancy. Have you? I mean, have you come across anything?
I think everyone's focused on the diagnostics, so X-ray images and MRI images and reading them. So they're focused
Mm,
in the right space, but
mm,
obviously that's kind of worldwide. So if
mm,
GE crack it or Philips crack it or Siemens, then they've got a product they can push worldwide, because obviously they got the scanners and hardware everywhere. So I think that's where the focus is at the minute, because that's where again they seem to be valuing in what they're doing in terms of now we don't need so many consultants to review an image. We can give the really accurate result of an image to a consultant to just verify rather than having to review. So I
mm,
think that's the right space where you find a
yeah.
lot of advancements in technology. There's Dr. Rizwan Malik from Bolton Hospital, who's a good friend I follow on LinkedIn as well. So he's doing lots of good things in that space. So over in Egypt and Saudi and a lot in the
Mm,
UK. So that kind of space is growing and where it is. And now you're finding a lot of these um, scribe technologies now where consultants can talk into a kind of dictaphone kind of style and it types out everything. But not only
Mm.
that, it kind of links into nice guidance, links into best practices, it understands the terminology, and then kind
Mm.
of summarizes it in a way where they can
Najum, sorry, I've just got
kind of,
someone at the door, mate. Apologies. I'll edit this later.
not cool.
Hello. Yeah, yeah, let me just grab a photo. Cheers, buddy. Thank you very much. Cheers. Good night. See you later. It's like Christmas every day with Timu. Most of it's crap though. I got this. I spent 25 quid on a survival kit. It's like a outdoor survival kit. It was about this big. It's like a survival kit for an action man or something. Anyway, sorry. Where did we get to? We're talking about large language models being deployed in the right sort of areas. Can you? Yeah. Do you want
Yeah,
to just carry on?
it's a large language module kind of deployed in diagnostic and imaging and
Mm,
scribe areas. So now you're finding a lot of dictaphones kind of scribing technology. You got Tortoise and a few others that are kind of allowing consultants in outpatient areas, so instead of having to have the consultant face to face and then having to type it into the EPR or type it into the medical record. Now, you've got the scribe technology that's scribing it, but also adding all the little bits that need to be added from the nice guidance and everything else, and then putting it into the EPR, which is fantastic. That's the kind of space you need
mm,
to give the consultant some time back. And even if it's 1 or 2 minute per outpatient appointment, a hospital has about 500,000 outpatient appointments
mm,
per year, on average. So again, it's a lot of time given back to
mm,
consultants, which is great and fantastic. As long as it's proven and as long as it's integrated so it can flow into the EPR automatically. Then the next
mm,
stage from that was can it manage the pathways? Can it know that Najum Khan needs to have an appointment booked afterwards for an image? So he needs to go in for an X-ray. So can it then go into the EPR and pre-book his appointment for an image? So that'd be
mm,
kind of the next level of things that you can see Oracle are talking about the new generation of AI-led EPRs, and that's where this should be heading in terms of now not just it going back to the PA of the consultant for her to then ring around and book an appointment and book the
mm,
follow-up, book the scan. It should automatically be doing this within the systems to give that time back in terms of not only to PAs but to consultants, to nurses, and to the
mm,
whole system. To be fair, and that's when you
mm,
get the dynamic movement of patients on a waiting list. Because now that patient wouldn't naturally be on a waiting list, it can dynamically say he's got his next appointment booked. What are the chances of him missing the appointment? How many appointments has he missed in past and history? How many times has he DNA'd? Do we have to even phone them up the day before? So again, those sort of things can go into a central call center. A
mm,
central call center can sit anywhere in the country, and then they get all this messaging. Like chase up Najim Khan 1 day before, chase him up 1 hour before, make sure he's there. If he needs to have a taxi booked, we've got a central pot of money to book him an Uber taxi to get him in
mm,
there. If he's afraid of parking, we'll pay for his parking. These sort of little things
mm,
where it really then brings the whole centre together because a call centre can be sat in Leeds and manage a raw free parking. Why is it not
mm,
possible? So
mm,
you can do all these things remotely. It's just for some reason our legacy tech hasn't allowed these sort of little innovative things to come out in the open, and that's where people need to be thinking ahead in is because that
mm,
administration burden is just as big as anything else. And that's where the whole concept around metrics, but also analytical thinker, which is
mm,
the kind of the next AI kind of tool that we're working on in terms of bringing all this data together to allow general manager to just ask it questions and it give it answers
mm,
back rather than having to go and find my dedicated BI person and
mm,
ask them a question for them to come back to me 3 weeks later with an answer.
mm,
But I need that answer then and then because my crew's asking me why did my A&E fail yesterday and why
mm,
do we have such poor performance? I need an answer there and then. Then you always end up having a unfortunate band A, B, C, or D. Being a BI person, finding the data, doing the
mm,
spreadsheet, doing it themselves. Now look at the cost and the loss in
mm,
productivity just in that one general manager who should really be managing other more important things, but he gets sucked into doing the low
mm,
level stuff because just the capacity is in there. So that's where I think
mm.
these models now, these AI models, large language models, they can really hopefully increase productivity in this admin space and this BI space,
Yeah.
and then it should be interesting.
Yeah, yeah, I was going to ask about that actually, sort of specifically within the BI space. So, do you know what the NHS policy is on sort of developers using language models to write SQL and build data warehouses and stuff? Are they okay with that, or is there's some constraints? Because I know the government were quite funny about it a couple of years ago.
Yeah, I think Microsoft licensing is centralized now. So in terms of Copilot, so I think each trust now has a means of buying centralized co-pilot license to use in the hospital. So again, it's one of them things where if you're aligned to Azure and all your data warehouse is in Azure and
Mm,
Copilot's looking at your Azure infrastructure and it limits it to your Azure infrastructure, then probably it's a tick in the box.
mm,
But the question is obviously if you're not on Azure, if you're on your own local data warehouse or SQL Server and you're using Copilot to link into that, again,
mm,
is it your tenancy? Is it a central tenancy? Where is it? So this way, I think again when you mention the point of the government doing things itself is the government really should look at setting up its own healthcare dedicated data center somewhere
mm,
where it can allow vendors to put their LLMs on there, and then from there it's on the old kind of infrastructure of the NHS, and it can access the data, and then it's not leaving your data center and not
mm,
going off to some sort of California data center or nowhere else where they can use your data, and therefore the vendors then put their technology on your data center, your infrastructure, you manage control it. Now, if anyone uses it, it doesn't matter because it's not
mm,
leaving that space, and they can have some tenancy on. So that would be a sensible approach to any kind of future AI kind of model where each
mm,
government should really be running its own data centers. Because
mm,
as we know, like for example, Google, it replicates all its data centers around the world, and it's got blockchain and however star schemes and however it's doing it around the entire world of all these hub and spoke models.
mm,
Therefore, your data, whether you like it or not, if you're using Google, will be around the world and replicated
mm.
everywhere. So you can't
Yeah.
control it. So
Mm,
hence why I'd thought by now they would learn a few lessons from other countries and start building their own healthcare
mm.
managed domain data centers.
Yeah, that's interesting. You should say that because I had a recent role with a group called Log. As you know, I think I spoke to you while I was on this contract. Logix. They're doing a project to try and gather sort of diagnostic information for certain conditions, and they deal with multiple European countries. And they said that England is one of the worst in terms of getting hold of the information they need, and it's kind of embarrassing. It was a bit embarrassing, because we've got one of the best healthcare services in the world. So why have we got this stuff so horribly wrong? I mean, I think there's certain financial incentives, aren't there, to complete some of the data in the SUS submission, so you don't get much, if any, outpatient diagnostic information. It's just that's so crap, isn't it? That it really is so crap. But yeah, I was going to ask you what you thought about the recent changes to with NHS England. I mean, Hugh said that the overarching plan is to essentially just get rid and soak up some of their functionality within public health. Was it Public Health England? What do you think
Yeah,
about that?
yeah, I think it's one of those scenarios where I think what's 18,000 staff are going to lose the job. Now, if you think about that in the grand scheme of things, it's kind of a drop in the ocean, isn't it? As to, we've got 1.6 million staff in the NHS and 1,800 staff are doing something. It comes back to that. You don't mind change happening if the plan was black and white and written as to what will
Mm,
happen tomorrow. But that's the problem. They've got rid of it and they've said something but we can't see it. So that's the
mm,
hardest thing. Is the hard thing is to judge something on something you haven't seen. So it comes back to the point if the federated data platform was going to be so extensive, if every trust already had signed up to it, if every trust was pumping loads of data into it, and you had a centralized team, NHS England, Department of Health, wherever they are, reviewing that data day in day out, and it had wonderful AI models that was doing all this analysis and accountability and checking that NHS England were doing today, then you can see a
mm,
like for like replacement with 10 people for the 100 people there, fair enough. But you can't see that.
mm,
So it's all theory at the minute.
mm,
So I'd thought it's a kind of bad thing to do based on theory when no one's achieved it anywhere in the world. No one has the NHS data levels we have, healthcare data levels we have anywhere in the world. So no one can prove the model. So
mm,
therefore, it's kind of unfortunately, it's kind of a finger in the air kind of scenario, isn't it? We think this is what's going to happen, but you've already
mm,
got so much fight back on people putting data into FTP. You've all got so much lack of data going in there. You've only got a handful of trusts really using it as their central data warehouse. You've got so many hospitals who are probably stuck on old Oracle infrastructure or old Microsoft infrastructure that they need to move across probably 5, 10 year contracts they've probably got signed with them. So they
mm,
have to let them run out before they can move across the FDP. Then, like we said before, you've got someone managing the old infrastructure and trying to build the new infrastructure. How can that same person do that? So you've got
mm,
that capacity problem as well. So unfortunately, they haven't really, I don't think, thought it through because all them individuals in NHS England could have been helping.
Mm,
You know, how many trusts do we know have gone live with an EPR and then gone backwards because
mm,
the adoption and training post EPR is not there that it was pre
mm,
EPR. So they could have utilized these 1,800 people in a better way, in each region. Say, right, go in and help optimize. You had some very talented individuals who knew a lot of operational ways of working, who had worked in hospitals and healthcare, in mental health, in community and social care. So we could rebadge them into different areas to help this kind of little hump, get
mm,
over the hump, and then yeah, fair enough, disbanding
mm,
1,800 people, and then it might be less people shouting about it because they can see the value in what you've achieved. But when you
mm,
do it before you achieved anything and it's based on theory, it just sounds like we move from the CCGs to the PCTs to the CSUs now to the ICBs and ICSs.
mm,
Where can anyone see any value in any of them changes? We just
mm,
move people around, giving them a different post, give them a different title, but no value in any of that. The commissioning has just been the same. If you look at PBRs, we've moved away from PBR to block contracts, back to PBR, then now we've got a hybrid model of some do
mm,
PPR, some standardize that because that gives you your underlining, major kind of gains and wins, and it kind of shows to you and naturally leads into the dynamic PTL because if you've got a hospital doing an operation once a year or one consultant doing one type of operation once a year, it's not safe and it shouldn't be done. But you can only see that through all the coding,
mm.
clinical code, and everything coming to a central point to say why is Najum Khan doing that type of operation in that hospital once? You might think he's good, but we've got this doctor
Yeah.
over here who's done it 15 times a year. He should be best doing it. So move the patient to where
Mm,
it's best for them. Don't let Najum Khan just guess at that surgery. Yeah, there might not be an issue, but the chance of there
mm.
being an issue is higher. And
Yeah.
this is where all the PBR, the coding, all this kind of thinking comes from. All this kind of, who's looking at roll three and ripping through all the operations they've done and understanding any safety concerns. Have we really alleviated the pressure? Have we look at obstetrics and look at the amount of maternity cases going through now in terms of maternity and the CNST, and it's going through the roof. We almost pay, I think, 3 billion. I looked at that last number in terms of backing damages and claims. So
Wow.
I'm pretty sure the 1,800 people could have helped somewhere
Yeah.
is rather than just being let go because you lost a
Mm.
lot of talent, a lot of knowledge, a lot of information.
Yeah, this is one of the things Hugh again was talking about, and he was talking about they're building this kind of consortium of expertise from different trusts across the country. It might be worth getting in touch with him actually, but these are interested parties that are trying to solve problems locally, reuse solutions from each other's trust rather than depending on too heavily on private sector or central government. Because, as you pointed out, government just mess around with the NHS every few years, don't they? It's like, oh, it's the last time. Well, it's been the last time 7 times. And it's like, what each party, each new incumbent has to flex their muscle, say, look at us, we're going to introduce it, we're going to cut waiting lists, we're going to. I mean, who introduced 18 weeks? I can't. Was that Tony Blair? I can't remember, but it's.
A long time ago, mate.
But they make this policy decision and it trickles down and it just absolutely it just messes everything up.
It's like the Lib Dems. One of them said the other day, we're gonna outlaw 12-hour waits. And I seen it on LinkedIn
Out.
post. I got it seemed the 12-hour wait issue isn't an A&E problem.
Mm,
Doctors don't happily keep you there for 12 hours because it's fun and games.
mm,
They keep you there for 12 hours because there's nowhere to put you.
yeah, yeah, yeah,
So
yeah.
it's not to do with his
I mean, I
choice.
don't. Have they really even sorted out weekend discharges yet? Because you always longest length of stay is people discharged on a Monday because you've got the extra 2 days because they're not being discharged over the weekend. And there's all these little things that everybody knows but never get sorted.
And that's the thing is when you come to weekend and out of hours kind of services and discharges, you always find you're right. It kind of peaks and unfortunate safety incidents happen on these times where the staffing is low. And then
Mm,
so hence why we've got to come back to why is the staffing burnt out so much during the week that they can't happily do it out of hours or on
mm,
weekends? Is because we've got so much burden on the 9 to 5 that
mm,
we haven't really the PTLs or elective care, we haven't really done something different. Said, right, why don't we do all these operations on the weekends? I know it might cost a
mm,
bit, but we can get the waiting list down, therefore alleviating the pressure on outpatient appointments. And first and foremost, during the 9 to 5, the kind of core 8 to 6 now for hospitals, meaning they can focus on the patients in the hospital and getting them out the door. So we
mm,
haven't really thought differently. You're right, this weekend notion, this winter pressure,
mm,
it's always existed. It's nothing new. It's just we've not
mm,
had the capacity to do something different. And these 1,800 people, again, could have helped, I'm sure, think of
Mm.
something different, or at least implement something different, or done a
Yeah.
kind of research study in West
Mm.
Yorkshire. Let's pick
Yeah.
West Yorkshire. Let's get 7 trusts together. Let's see if we can do something different. Let's
Mm.
bring everyone's PTLs together, review them patient by patient to understand, is this genuine or not?
Yeah.
Because as
Yeah.
you know, and I know a lot of the waiting lists are kind of patients that might have been on there historically, but when you
Mm.
read their medical record, they kind of just need something minor,
Mm.
and it can probably be done pretty easily and fast. But because
Yeah.
you don't ring up and complain, they don't ring about their pain, they're not back in A&E, you think, oh, they're okay, let's put them down the list. But whereas, oh, this patient's ringing up every day and complaining every day, let's get them done first because they're complaining, let's get them off the list. So
Mm.
again, fortunately, you're right, it's
Yeah.
just
Mm.
day-to-day firefighting rather than anyone just sitting back and saying, and that's what NHS England really should have, the 1800
Mm.
could have done, sit back and say, "Oh, we want the pressure on us. We can now look at the system in a different way in the new world order of the FDP, of a dynamic PTL, or dynamic bed management. What could we do differently to help
Mm.
the system? And look at in the regions, West Yorkshire, and with 6, 7 major hospitals, I'm sure they could have done something fantastic.
Mm. Yeah, well, I think that's the kind of thing that NHS England were doing. I mean, I worked with them on winter pressures a few years ago, based up in East Anglia somewhere, Cambridge it was, and there's some really good work going on there with the Opel sort of operational escalation numbers, and we're integrating loads of data, look at capacity, inputs, outputs, this kind of thing, bed delays, and I mean, it looked useful to me. So I'm sure there's tons of brain power inside NHS England that could be deployed on some of this stuff, but again, it's just one of these sweeping government changes that we can't do much about, really, isn't it?
Exactly.
So,
I've just got
Najim,
to
can we
go.
talk a little bit more about sort of like the internal structure and process, bottlenecks, things like that inside the hospitals, and what the best approach to that is? Because you get these odd ad hoc bits of analysis, and they say there's something going wrong here. Can you look into it? But is there a methodology or an approach to this you'd recommend?
Yeah, so thinking about hospitals, obviously that's where you unfortunately got a lot of high spend in terms of you got your kind of high consultants, high nurses, got a lot of spend there, a lot of budget there per year, and I think things need to be looked at a bit more detailed. You look at these major EPR programs, it's the right thing to remove paper and to put it into a digital record. That's fantastic. That's kind of level one. But what we really need to do is start to operationalize this data. So kind of that's the beauty about iBox. That's where I've been really working heavy on in the past 10 years. I've literally lived in site offices, and right now at George Eliot, we're really pushing forward in terms of simple little things like notification. So the site office kind of say, look, Najim, when a patient gets discharged from a ward, what would happen pre-iBox is Najim Khan gets discharged, he's gone home. The nurses clearly are really busy, running around. The ward clerk then updates the PAS system probably half an hour later. Then from there, the ward clerk might ring the site office saying Najim Khan's got a discharge. We've got a bed empty for someone. Then it'll take us half an hour to find a patient in A&E. So right, that patient is applicable for that bed. Let's move them across. She's talking a good 2 hours of just lost in terms of communication, and that's if everyone picks the phone up at the first time and everything goes smooth. So we've implemented simple things, just notifications within iBox. So hence why I keep coming back to the point of system centric versus patient centric. So yeah, the patient's care is done in the EPR. Najim Khan's discharge off the EPR, fantastic. But then the system gives that information back to the site
Mm.
office to know that bed is empty. I know I can move that patient from A&E into that bed to alleviate pressure of a 12-hour breach. And therefore they know what they can do electronically. Then they can trigger that ward to say, right, move the patient into that bed. On the big screen, the ward get a notification, right, that bed's been allocated, X number of patients coming up, get ready for a handover. They know
Mm.
what has to be done and they get on and do it. So it kind of smoothens that transition between these little kind of communications to take away the need of a phone call or a
Mm.
ward visit. And that's kind of where you get the productivity going and the
Mm.
digitalization coming back. Now looking at George Eliot, this has been over a 3 year piece of work. It's not like I've rocked up yesterday and done all this. So we start
Mm.
with A&E kind of light and small. Then we worked with the kind of fast flow wards in AMU. Then we worked with the medical wards. Then we worked with surgical wards. Then we've taken the discharge tracking team off their spreadsheet. Then we worked the infection control team off their spreadsheet.
Mm.
Now we're going back to the site office here, right? We've got a lot of this data now. Let's take your bed spreadsheets out from your bed meters and digitize them. So it's about
Mm.
mapping out that transformation journey
Yeah.
and being along them on the journey with them and
Mm.
making sure that I've done iBox before at
Mm.
Northampton or Kettering or somewhere else, but this is George Eliot. They work
Mm.
differently. They've got
You're
more medical
organically
wards.
growing it with them, and so they're invested in it as well, and you ensure that you get that local expertise in the mix as well.
100%. So even moving them off the discharge tracking spreadsheet that they had took 6 months because they were
Mm,
so wedded to it in terms of how
mm,
it was working and what it was giving back to them. It took a whole 6 months of working with them slowly, piece by piece, taking it off them. And then post go live of the iBox discharge tracker, they've still had 6 months of changes. So it's about
mm,
understand that, yeah, everyone thought something, we delivered it. But when
mm,
we did actually deliver it, actually, could we do this, and the other? Just
mm,
colouring boxes green if a patient's ready to go home
mm,
today, marking someone red if there's an action outstanding. Simple little things that we've implemented afterwards to
yeah.
allow them to then work more efficiently. And now they're ready to iBox and the discharge track, and they can't think of a day without it. So it's kind of going on that journey. I think that's what we're lacking in terms of these EPRs and these
Mm,
programs we've got. Is there's a lot of emphasis, a lot of major pre-go live kind of oomph. And then after go live, all these contractors vanish, all
mm,
that knowledge kind of goes in terms of why they configured it the way they configured
yeah.
it. Then post go live, you've got like a
Mm,
change analyst of two people, a change team of two people, and one kind of manager
mm,
doing it on a part-time basis. And then they wonder why they've not optimized
mm,
the EPR to work how they need to, and then
yeah.
why the operational teams have 200 spreadsheets that just give them the
Mm,
data they need in
yeah.
hand there and then.
And then they end up
So,
spending 2 million quid on fixing data quality and RTT reporting 2 years later. That's
and
this
that's the
kind of
key
thing.
thing.
Yeah, yeah.
The ultimate thing what I see in hospitals is, especially with iBox, is what I found is when you give them that real-time data back, they understand why they're putting it in. So at the
Mm,
minute, if a
yeah.
doctor has an EPR system and I put in the data at 5 o'clock when my shift finishes, I'm putting the data in at 5 o'clock.
Mm,
No one questions me. Why
mm,
am I going to change my way of approach? I'm always going to put it at 5 o'clock because you lot are working off a manual whiteboard somewhere and
mm,
you're counting bean counters over there. But in George Eliot, if they don't put the data in real time, when it comes to their bed meeting, the site office call them out and say, hold on, you've said there's two patients definitely to go home today
mm,
on iBox, but yet on this piece of paper you're saying you've got seven. Why have you not
mm,
updated iBox? So they hold them to account, which means they know the data is being used in real
mm,
time
yeah,
to help patient flow. Therefore, they use it in real time for entering it, and that kind of cycle is complete.
yeah.
Whereas if it's not complete, consultants, doctors, wards,
Mm,
whoever they are, will just find a reason not to put it
yeah.
in real time, meaning the whole cycle isn't complete, meaning the site office, the central
Mm,
hub of hospital, can't run on a digital system. Then it has to, right, go get that manually, go to that ward and find out how many beds are really have empty. Did the
mm,
cleaning actually happen on time? How many
yeah.
tasks? And that's when the kind of whole thing breaks down. That's why the whole
Mm,
digitization, the digital transformation kind of project is really more post go live, I would say, than pre go live, and that's where hospitals
mm.
kind of win. When post go live, they've got a good team and good structure and good data foundations to take them forward.
Yeah, I like that. There's something really important about that idea that they're seeing the results of their inputs. A lot of people are just totally disconnected from the rationale of these processes, aren't they? They're putting stuff in, but they don't see anything change. Whereas you're saying, so it's a real time system. So they make changes. It's reflected on the system, and they can see that feedback whenever they want. That's
Yeah, so even like a deteriorating patient, when they were completing tasks in real time, there's an entire performance dashboard that shows them how many patients are on the list, how many tasks of them patients have been completed, how many patients were moved off the list, so they can start to
mm,
see their real performance in real time, understanding that as they complete a task and tick it off on the front end,
mm,
that the operational metrics used by the senior management is reflected in real time. So when it
mm,
comes to that handover, which is key, so one comment I made in terms of a 12-hour wait in A&Es, you ha they're moving between shifts. So if a shift is 8 hours and you're in the department for 12 hours, you most likely see two different consultants at two different times or two
mm,
different senior clinical individuals. Now, if that handover hasn't been slick and clean and good and digital, and it's been manual, how much information do you think is going to be missed
mm,
by a consultant who's just
yeah.
seen 40 patients on his shift? He's not remember every story from A to B. He's going to annotate it, miss something off. That consultant's going to go have to back around and say, Najum,
Mm,
so it was your left leg hurting. I'm going, no, it's my right arm hurting. Then he's going to have to start all over again. And you wonder
mm,
why the delays happen because he hasn't got the time to update the digital system in real time. He hasn't got
mm,
the time to read it all in real time. So therefore, you get all this disconnect and different things happening. That's why these 12-hour waits, I feel a lot of them end up with serious incidents and serious safety concerns, and unfortunately, death in some scenarios is
mm,
because of this just digital handover, this entire
mm,
process. No one's really got a handle on and thought about.
Mm.
and really drive it through in terms of a post go live of a digital solution.
Mm. That reminds me, actually, you talked about incidents there, and a lot of trusts use Datix, don't they? So have you done any integration with that as well? Because that's, I mean, that's something else I've observed is that those kind of systems aren't integrated with activities. So, you can look at your say, outpatient activity, but you don't know that one of these guys has slipped over or something in a ward 3 months ago. It's not integrated. Have you done anything on incidents and Datix?
Yeah, safety is a big area. So the beauty of the deteriorating patient at Northampton is we reduced all serious incidents in the entire department. So we had zero SIs across the entire department whilst implementing iBox.
So
That was
just
one of the
briefly, that's
key
that's
features.
a serious untoward incident, right? So that's
Yeah,
like some people call them never events, or are they different?
no, so never events are different. Never events are
Right.
like leaving some piece of something inside you once I've done a surgery, which is
Right.
kind of it should never happen. A
Yeah,
serious
yeah, yeah.
incident is maybe just something, I didn't get to you in time to observe your vitals, and therefore you've deteriorated faster than you should have done. So it's kind
Right.
of a serious incident, or not doing an AKI or
Mm.
sepsis screening on this patient. Then unfortunately they've had a serious incident of sepsis, not probably
Mm.
died, but just the care should be managed a bit better
Yeah.
in that regard. So we reduce all the SIs in Northampton. But you're right, in terms of Datex, again, it's another standalone system, another
Mm.
silo with a rich bit of information where
Mm.
people put a lot of information into there.
Mm.
Unfortunately, it's a lot of unstructured data into there. So the problem with these systems of unstructured data is it's very hard for someone to align that to an episode of
Mm.
care or time of care or
Yeah.
reason for care. And in the NHS, as we know, I think a recent, if you look at the black box thinking book, it was interesting. He said if the airline industry was run like the NHS, you would have 9/11 happening every single day.
Mm. God.
That's how
That's
bad
terrifying.
they.
And they're both, but the thing is, they're both safety critical, aren't they? The NHS is, safety critical. So,
Yeah, and that's where you've got and in another study was I think only 5% of incidents in the NHS are ever recorded. So if you think of the
mm.
levels, it's kind of wow, are they not recorded because of fear? So if
Mm.
I'm a lower down FY1, I'm an under senior registrar. If that's
Mm.
how it works, if I have to kind of dob him in, is my career at risk?
Mm.
So
Yeah.
I'd rather
Yeah.
just let's let that one go. It's all right, doctor. I'll patch him up. So
Mm.
is the fear there, or is there just a time and a reason to do, it, or is there nothing coming back? So I've put
Mm.
all these complaints in, but there's so unstructured data, no one's had time to read it and senior management have time to make a change. Oh,
Mm.
I see a change after 12, 18 months. What's the point of recording it? That's the whole point of notional real-time data coming back. If I'm
Yeah.
hammering all this data in and it comes back to me 6 months later to say, yeah, you should have treated that patient like this, it's kind of like,
Mm.
why am I even putting this in the first time?
Yeah.
So I feel with Datex and serious incidents and that kind of space again, it's just like the workforce rostering data. It's a silo system sat in the middle of
Mm.
nowhere. The
Does it?
IT teams,
Sorry, go on.
I said, the IT teams know something has to be done about it. They probably have got it in the data warehouse
Mm.
somewhere, a Datex
Mm.
link. But
Yeah.
have they put that together with all the flow and incidents and
Mm.
everything else that kind of triangle when we are higher risk of a safety incident happening?
Mm.
Again, you need workforce data, you need activity data, you need Datex, and you need a clinical person senior to review it and to really bring that together. And so it's a very complex piece of work, I think, and I can
Mm.
see why no one's really tackled it head on.
Yeah, we did something along those lines years ago. It was Oracle OBIE based. Barnet and Chase Farm Hospitals, a brilliant data warehouse manager up there, Mahesh Koramutla, actually. I don't know whether you've ever come across Mahesh. And also Natasha Phillips, she was the chief nurse there. And we set up a kind of data collection system for risk assessments and care planning, and then we integrated some of the Datix as well. And we could literally see that there was a reduction in incidents on those wards that had been doing the proper risk assessment and care planning. So I was going to ask you, do you know of any EPR systems that do that? Actually associate some of the nursing care quality stuff within the system, or again, is that just one of those big gaps that need
Yeah,
filling?
so at the minute they've got to register acuity of a patient at a certain point in time. So the acuity of patient determines the nursing kind of to patient ratios. So they do record some of this, I believe, in the EPRs, and then they put it across into the safer staffing tool that says, right, this is how many nurses you should have on a ward, and this is kind of how your
Mm.
workforce should be kind of set up in the ideal scenario. But as we know, with a high vacancy rate, high sickness rate, outbreaks and other things, they can't always do that. So it's kind of
Mm,
interesting in that, yeah, something like that should really be triangulated in real time, and it would be fascinating if you could triangulate how much workforce you have in today, what's the acuity of every single patient, so you start to know what they're going, and what's the kind of an index value. So
mm,
that's very interesting. So I've just started to put together a piece of work called the Patient Acuity and Workforce Index. So I've been looking into this and thinking, how can we create a four kind of quadrant of high acuity, high workload, low acuity, high workload kind of scenario where,
mm,
yeah, Najum Khan is coming into the hospital, his acuity is high, but his workload is low because his acuity is high because of one kind of comorbidity, meaning, yeah,
mm,
his workforce index is kind of low, but we know he's high acuity, so keep an eye on him, but he doesn't take much strain because he's only been in hospital 2 days. Whereas another patient might have high acuity but been in the hospital 17 days, but come
mm,
with multiple comorbidities, meaning, right, he's got multiple reasons to be there. His length of stay is high.
mm,
He's actually on a package of care where we need local authority involved. We're going to have a lot of chasing there. He's had multiple historical infections. He's
mm,
got current infections. Right, his workload is high. His acuity is high.
mm,
Man, this patient's going to definitely be a high length of stay patient. So I've looked through all the
mm,
kind of recent kind of safety paper and other things, and I've not really found we've got an acuity score in there, but not really found someone who's brought together a whole host of metrics to determine
mm.
patient acuity and workforce index. Just what I'm
Yeah.
trying to derive using data from George Eliot. I'm trying to work with a nurse there who's going to be a long. They normally have these length of stay coordinators or kind of definite discharge patient
Mm,
coordinators or patient flow coordinators. So they're hiring an individual to look at long length of stay, and she's going to be a nurse as well.
mm,
And my paperwork is going to go together with her, and hopefully she'll drive from a clinical point of view. I'll drive from an analytics point of view, and
mm,
together with that patient acuity workforce index, I'm hoping comes to life. It will
mm,
really start to drive George Eliot saying, because we've only got to find that number of resources where you focus in your effort and be careful of this patient and be careful of this reason. So not
mm.
only does it brings in deteriorating patient in terms of high acuity, I'm trying to bring in the workforce element
Yeah,
in
yeah.
terms of how much workforce you need to manage this patient because of the different pathways he's on and because of the different historical kind
Mm,
of historical events he's had with him and because of your strain on your workforce across your
mm.
entire estate. So
Yeah.
trying to triangulate that together. So
Do
with the
it, basically
patient
doing it more scientifically because at the moment at high acuity, just the assumption is it's just going to be more effort. You're saying actually no, it's a bit more fiddly than that because you could, as you say, you can have high acuity patients that you don't have to do anything on. You just have to keep half an eye on them. But yeah, that's fascinating. And again, this I take it this is based on sort of empirical research, and you obviously made some findings and saying actually this guy's high acuity, but there's only one nurse needed for him or something like that.
Yeah, exactly. So what I'm doing is bringing together the history. So because we've been at iBox, we've been in Georgia for 3 years now. We've got a lot of learning in terms of medical patients, length of stay, ward movements.
Yeah.
So even a simple thing like continuum of care. Why have you moved this patient 4 times within inside your
Mm,
hospital? So every time you move a patient, you risk infection. You risk them moving to a different space, being looked after by a different team,
mm,
meaning you've got to redo
yeah.
something. But
Psychologically disruptive. It's not good for
yeah,
healing.
exactly. So it's not good. So that reduce the number of moves. Hence why everyone says, right bed, right bed, right time, right patient, right bed. Is that getting the patient in the right space at the right time, least number of moves,
Mm,
least number of interaction with different workforce, meaning that the one nurse that sees, yeah, I run Najum, I know what it's got. You build up that rapport once a patient, and then that way you find through therapy that the patient won't be discharged faster. So I'm trying to really home in and try to put some science behind it in terms of you look at internal moves, looking at the acuity of the patient, not just looking at the current acuity, but thinking has the acuity gone up, gone down? What's the kind of
mm,
index of it? What's his history on acuity? Then look at the multiple comorbidities. That's pretty important. Does he have diabetes? Does he have any other long stay kind of long term condition that we need to look after?
mm,
And infection is big as well because if he comes in with a past infection, but he gets a different infection, then that could trip over into other things, into other breaks. And then he's thinking about, you know, controlling the outbreak because it's not only patients that get sick, it's the staff that get sick.
mm,
So if you don't control the outbreak, you might have 3 or 4 staff that end up with an infection that might have to
mm,
take annual leave or might have to not be allowed to be back in the hospital. Therefore, you're increasing your lack of staff already at a time where you've got a major outbreak. So hence why
Mm,
the infection control module comes into play. And how many patients do you have infected? How many side rooms do you have? How many cleaners do you have to clean them side rooms? Because you've got to have a cleaning matrix to understand a different type of infection needs a different type of clean. How long does it take? And then all that impacts your bed turnaround time, which impacts your site flow, and then knock-on effect to your A&E.
mm,
So you really got to triangulate a lot of metrics. So I'm trying to triangulate them in this PAWI, this patient acuity and workforce index, to try to give the hospital a very detailed view, not just of here's your five longest stay patients, or here's everyone who's over 7 days, 14 days, 21 days, which you kind of do the stranded, super stranded kind of stuff. That's kind of, in my opinion, archaic. It should really bring in a lot more data, and especially with
mm,
these EPRs and having all this data in there.
mm,
You've got a lot of them integrated with observation stuff. You know who's gone into theatre and who's not gone into theatre, who's due, what the history of the patient, who's due a diabetic review or a sepsis review or therapy, who needs to get some salt, the speech and language therapy kind of interventions. So you know all this information from the EPR. It's about
mm,
triangulating it and giving an index and trying to help direct the workforce to the most sickest patients, but also the most needy patients to understand. But then it's also understanding why we are where we are, because you've got a lot of patients who are high on the workforce index and high acuity. You
mm.
understand why your workforce is unfortunately busy and drained, and where they are, because you've got a lot of patients who, unfortunately, 20% of patients are now grown to 30, 40% of patients who are stuck in your hospital rather than the 10 or 15 that you need to get it down to.
Mm. That's fascinating. I tell you what's really reassuring about this conversation. I'm talking to a data and IT professional, right? But we 90% of this conversation has been about the patients. And that's what really heartens me about this, because that's what the whole thing's all about. And it sounds like you've just amassed an enormous amount of knowledge from your own data as well. So you're hoovering up data to try and tackle business questions and tactically support decisions and stuff, but it also gives you this developing history, and presumably the data is getting better as well, because you're saying actually maybe we should collect this and refine this, aggregate this in this way, and so on and so forth. So it's growing organically in all directions, isn't it? And I love that. I mean, is there any chance of upscaling some of your work and sort of getting it to a, to a, up there to a higher audience, sort of take it to them and say, look, we've got some solutions here that can work for almost any hospital? Because I mean, you've got experience across loads of different EPRs, loads of different, peripheral systems, diagnostics, so on and so forth, and you've interfaced with them all. And it sounds like you're making a difference. So has that been? Have you thought about that? Go and give a presentation to the, the health secretary or something. I'll
Yes,
drive. I'll drive you.
no, no, yes, I think it's one of them things where unfortunately connections matter in healthcare. I think who you know matters. If you look if if I be realistic, when I started iBox, I was thought, I've done it once. I could probably copy and paste this and do it a lot more times. It's not worked like that.
Mm,
It has
yeah.
been about who you know and your personal connections and that trust. So it's grown organically into 3 or 4 hospitals and up and down. So it's one of those scenarios where, yeah, I believe something like this should be looked at nationally, because from my view, every A&E department should have an A&E iBox module or something similar to it if they don't have it. The breach validation tool we built in there to automate breaches
Mm,
and to give the live view back in terms of your A&E bottlenecks and how
mm,
about and historical look back.
mm.
That kind of thing should be
Yeah.
standard.
Yeah,
And
breach
when you
validation,
build it,
spreadsheets, bits of paper, phone
exactly.
calls. You bump into someone in the corridor, say, "Yeah, we got another one. Can you add it on?" It's like it's an absolute joke, isn't it? Sometimes, yeah.
Exactly that. So even doing something, even helping them build something like that in Microsoft or Tableau or whatever they want to do, and disseminating it from a national point of view,
Mm,
I think that should be kind of done. But that's kind of the hardest thing, is that these hospitals at the minute are in FDP mode. So when you talk about analytics to them, they kind of, "Oh, hold on a minute, we need to see what the FDP comes up with." This is my whole issue with the theory versus the actual. So, I've
mm,
actually done it. You're waiting for a theory-based solution,
mm,
but because it's from the central pot and it's kind of free, I'll wait for this one over here, whereas you're going to cost me X number of £1,000s.
mm,
So that's the problem you've got at the minute. And obviously with Wes and everyone at Centrally, again, they're all looking at the FDP, but someone like you and me would say, well, it hasn't delivered much yet because it's still probably 5 years, I would say, away from maturing, and 10 years probably away from delivering real value, because just the juggernaut of data it's going to have.
mm,
Whereas you need a problem solving today.
mm,
Hello, I'm here today. I've done it today. So why don't you just let me roll out something today?
Mm,
And this is what I say to trust. Go, look, roll out iBox today. If tomorrow your internal team builds something fantastic, which is better,
mm.
just decommission it.
Switch off iBox.
Pick up iBox and hand over. But
Mm.
you know as well as I do, the
It ain't gonna
chance
happen.
of doing it is very remote. So
Yeah,
therefore, it's kind
yeah.
of that's what and you're right. That's where national conversation will come in. Is
Mm,
yeah, the theory is fantastic, FTP fantastic. I understand
mm,
what you're trying to do with the theory, but they haven't delivered it. They
mm.
haven't got that there
Yeah.
for whatever reason. So therefore, and not every trust has it as well. So you're going to
Mm,
have, just say you got 50 trusts on it today, you've still got another 100 to mop up, yeah? So them
mm,
100 that you're still working with, why don't you let them have small tools like this that can help them today, help them the winter today, help them maybe next winter, and probably a third winter after that, you built a tool, fantastic, move it across, decommission
mm.
iBox.
Yeah, yeah.
So
And the fact that you're doing the anthropological piece, you're living and breathing these workplaces, you're involved in the process, you're sat with these guys and working with them. That's fantastic because all too often you get like a consultancy solution. It's remote, a bunch of requirements are put down. It's like a high level description. You ask for a toaster and you get a kettle, right? And whereas you're actually organically involved with them, and obviously internal staff do that as well, and there's some great expertise inside the NHS, but you're gathering knowledge from all the different trusts. So you've got the best practice thing. You've solved a problem here. You can solve it elsewhere. You should talk to Hugh actually. Because he's talking about this sort of this collective of expertise, trying to save trust money. It's entirely aligned with what you're saying. He thinks there's far too much, big consultancy, private sector involvement, far too much government interference. They're talking about building this group of sort of people who are immune to that. You know, well, they could read it in the news if they want, but they're trying to be just pragmatic with the skills they've got in house, the tools they've got, the lessons they've learned internally and elsewhere. And this is what we need really for the NHS is brains that have soaked up the culture and the experience and worked inside the trust as you and I have, talking together about how to solve these problems nationally because it is embarrassing that one of the supposedly one of the sort of financial leaders. Research is brilliant here. Our universities are fantastic, and our hospitals are fantastic. So why can't we describe them properly and what's going on and why? But yeah, we're getting there thanks to people like you, and just thanks for looking at this stuff because again, you're not just looking at the numbers, you're looking at the people and the patients thinking, actually, what is causing this 30% dip in efficiency? What is really underneath it? So yeah, that's really good, really reassuring. Was there anything else you wanted to talk about, Nadja? I'm just a little bit conscious of time here, but
I'm good, man. I've covered a lot there for you. You can have confused me. So I've covered a
it's
lot
no,
there
it,
for you.
it's rich. It's rich content, mate, and it's coming from the right place. And it's been a real pleasure talking to you, Najum. So hopefully we can talk again. And I'm thinking of doing some sort of group chats as well. Perhaps we can sort of discuss this with some other experts, probably debate some things. So if you're interested in that, that's cool too.
No, I mean, no harm in that. Definitely get a few of us together and see what's happening in different hospitals. And everyone's got different experiences. Everyone's got different, unfortunately, touch points, and everyone's been at different levels. So
Mm.
it'd be good to hear, probably from some execs, some higher up in terms of the problems they're facing. Whereas,
Mm.
we're kind of down at the lower end of the data number crunching and doing it. So it'd be interesting to understand, their problems and their issues versus, us doing as well.
Brilliant. I mean, you've kind of captured a little bit of why I'm doing this. I want to gather all these different stories, find out what's going on, find out what people actually believe is going on. So there's a sort of philosophical, there's a bit of science, bit of culture, bit of politics, and you've been a big part of that. So thank you so much, Najim, and we'll speak soon. Yeah,
No, thank you for your time, Matthew.
take care, mate.
Cheers, man. Cheers. Bye.
Hey guys, just finished editing this. What a fun interview. Really, really detailed, packed with information, ideas, insights about healthcare processes and finances and the culture and the politics of it to some extent as well. So, what a welcome addition to the healthcare series of interviews that I'm doing. So that the second guest, really, really fantastic. I hope we can talk again and again. We're going to look into doing some sort of group conversations, get a few more experts around the table. Thank you very much. Bye bye.